Welcome to the School of Population Health UNSW In Perspective seminar series. I'm Rebecca Ivers, Head of the School of Population Health here at UNSW, and I'm delighted to welcome you all to this very topical and important panel discussion hosted with Oxfam Australia. Many of us are meeting today on unceded land of Aboriginal and Torres Strait Islander people from across Australia, and I'm coming to you today from Gadigal Wongal land in Sydney, Australia. I acknowledge the traditional owners of all the lands we meet on today, pay my respects to elders past, present and future, and acknowledge the strength and richness of the most ancient and enduring culture on the planet. I'd also like to extend a warm welcome to colleagues and friends joining us today from the countries of the Pacific, and acknowledge too the ongoing custodianship and care of Pacific Island peoples for their land. And of course, welcome to all others joining us today from across the globe. The topic today is on the impact of COVID on the health systems of the Pacific. While border closures have effectively protected some Pacific states' health systems from a surge in COVID cases, as has occurred in Australia, they've also had unintended consequences, including breaking essential supply chains, disrupting really essential healthcare delivery and destabilising health programs. And that's going to be the focus of our discussion today. I'm going to hand over now to our chair, Dr. Adam Craig from the School of Population Health here at UNSW, who's been working with colleagues in the Pacific for many years. Adam has decades of experience working with a multitude of international agencies, including working as an epidemiologist with WHO in Manila on the 2009 influenza pandemic and on early warning surveillance system design in the Pacific Islands with colleagues from the Solomon Islands, Vanuatu, Fiji and Kiribati. His research interests relate to surveillance system design and health system strengthening with a focus on small island developing state context, so he's well situated to chair our panel today. Over to you, Adam, and I'm really looking forward to being introduced to the panel and hearing the discussion. Thanks very much for joining us.
Thanks, Rebecca. And I'd like to just acknowledge traditional owners too, and that I'm coming to you from Wongal land in the inner west of Sydney. Thanks for joining us on what's set to be a really wonderful discussion with four eminent and passionate public health experts on the topic of the hidden impacts of COVID-19 on the Pacific. As Rebecca noted, this seminar has been co-hosted or co-delivered by Oxfam Australia and the School of Population Health at UNSW. Joining me today is Lynn Morgan, Nima Askari, Stephanie Williams and Sunya Soakai. Lynn is the CEO of Oxfam Australia, where she oversees the delivery of a range of development programs. Within Oxfam's global family, Lynn is the executive champion of race, representation and equity. She sits on the Australian Council of International Development's board and on the trust board of Oxfam in the Pacific. Nima is a public health physician with over 20 years experience working in global health. Since 2016, Nima has been the director of the Asia Pacific Observatory on Health Systems and Policy, a role that involves the provision of policy advice to governments across the CIRO and WIPRO regions of WHO on issues critical to health system strengthening. Prior to joining the APO, Nima managed WHO's non-communicable disease, health and trade, human resources for health programs, among others, in Thailand, Cambodia and China. Stephanie Williams comes to us from Washington, and Stephanie is Australia's Ambassador for Regional Health Security. In this role, she supports the advancement of Australia's interests in the Indo-Pacific region by fostering linkages between Australia's public health and medical research experts and DFAT's priority programs and development aims. Steph guides the implementation of Australia's $300 million health security program and $523 million vaccine access initiative. Lastly but not least, Sunya is the Deputy Director of the Public Health Division of the Secretary of the Pacific Communities, or Pacific Communities, a role that sees him oversee the organisation's work in a range of areas, including trade and health, NCD control, outbreak surveillance and response, and health system strengthening. He has over 35 years of public health experience working in health system reform and different policy roles across the Pacific Islands, including his home country of Tonga. Welcome to everybody. The format of today's seminar will be very informal and more of a chat than presentations. I'll ask each of the speakers to very briefly respond to a question at the beginning, and then we'll engage in a discussion. Please post any questions you have for the panel in the chat. If you can, direct those questions to one of the panelists, and we'll get through them as we progress through the hour. So to start, I'd like to invite each guest to make comment on a general question. What has the COVID-19 pandemic meant for health systems across the Pacific, and where do you see the greatest impacts have been? Lynn, can I start with you?
Thanks, Adam, and to our audience, and also Rebecca, that warm introduction. I'd like to start too by acknowledging country. I'm coming from the land of the Wurundjeri here in Melbourne, and pay my respects to elders, past, present, and those emerging, and also any Aboriginal or Torres Strait Islander people who might be with us in our audience. I also want to acknowledge that in some respects I'm speaking to communities and contexts that are not my own, so I place that caveat on any observations or reflections that I might make. They're very much coming from Oxfam's broad understanding and my positioning here in Australia, looking at our policy and interventions and efforts. So it's from that place that I speak. In framing my answer to that question, and I guess this session and our interest in holding this session, I think about this in three ways broadly. Firstly, what is it that this time we could say we've done well? So where do we think that we have really responded to the challenges? And in saying that and acknowledging my fellow panellists, I really want to acknowledge that we're the folks that are doing the work. These are powerful people who have been working hard on this issue for a long time, and I just kind of want to acknowledge that we are part of that work and that solution. I also want to look at the things that perhaps haven't worked so well, and then, what does that mean for us in the future? Broadly, what did we do well? We pivoted well, and I want to acknowledge particularly DFAT in our relationship as Oxfam Australia, the effort and consideration that went into responding to what was happening and making the changes that were necessary was outstanding. But centrally, it relied on prior investments. In order to do the things we did well, we used the work that we already had done in building civil societies, creating strong communities, enabling these issues that are now questions of sort of medical and health intervention to be situated within a community knowledge and understanding. And so the big risk for us going forward is that we have raided the investment and resources that we need to ensure that that broader community context is as strong and receptive and capable as it can be to respond to specific and particular health system interventions. Because I'm sure I don't need to tell everybody here that the centrality of that community piece to the effectiveness of any and all of our health interventions, vaccines or otherwise. So we at Oxfam Australia would say that the challenge going forward is to get all of our development investment on the right footing and to understand that the pandemic has in some respects been, a health crisis, but it is ultimately an economic crisis of gargantuan proportions, and that will have profound impacts for the systems that are available to us to utilise into the future. So that's my 3 minutes, Adam. Thank you.
Thanks, Lynn. Can I pass over to you, Nima?
Sure. Good morning, afternoon, evening, everybody. Let me follow with what Lynn was saying with the last sentence, and I think that's actually a critical factor. And I think there has been a discourse where we're saying that health should not be seen as a cost issue. It's actually an economic development issue. And I think COVID has brought that very strongly to the forefront. It's brought in the fact that an outbreak has impacts which is not just in the health sector, and there's been huge issues in the health sector when it comes to COVID, not just on management of the COVID itself, but also in the other sectors, immunization, NCDs, even communicable disease control issues on the wider front, where they had to take a backseat while countries were trying to figure out what to do with the emergence. But it's also very clearly indicated that there is extremely strong linkage between health and the wider economy as a generator of income, as well as a, in this case, in a lot of countries, as a dampener of economic growth and income, unfortunately. And I think that's something that we've all acknowledged. We know that's happening the case. And I think in any country which is relying on a particular source as a major income, as a major economic area, So you're looking at the countries which have got to like the blue ocean economies, where you're looking at very specific one or two sources of economical growth, like fishing, like tourism, which is a huge impact. This is being amplified even more so. But it's been the case across the globe, across Asia, that it's had a huge negative impact on GDP. So I think that's more or less my 3 minutes. Thank you.
Yeah, good point. I mean, it's obviously not a COVID pandemic has exposed, the fragility of systems broadly, and the indirect and direct impacts of those have been recognised perhaps most acutely for the first time. Steph, can I pass over to you?
Yeah, thanks. Thanks for the opportunity to join today. I think we're still intra-crisis, right? We're in a pandemic era. We think we as humans have so wanted to see this as a 2020 event, and a 2021 will be better, and maybe 2022. But the virus isn't seeing it that way. And certainly every message from WHO is we're still in a very much of an acute phase. So when the question is about what has been the impact, I think it's obviously going to be variable and context specific. And Lynn brought up this is context specific knowledge and experience across Pacific Islands that is different. But earlier today, I spoke with the Pacific Island Health Research Symposium, and I talked about what I thought COVID had revealed about the strengths of Pacific health systems and health leadership. And they were echoed in the Global Preparedness Monitoring Board report from 2020, which said, well, what made countries do well? Actually, it was when you had evidence-informed, responsible leadership and engaged citizens. And when I just from an observer's perspective, those features have stood out in how the Pacific health systems individually and then through regional leadership, which Sonia will demonstrate no doubt, have come together to forge, solutions, agree on evidence and work through the crisis together. It's not to say there aren't challenges, and I know the purpose of this session is to talk about some of the impacts. And I think, the key vulnerability is that there just are not enough resources in stretched systems to begin with. And here we have an event that has diverted all attention and all effort in so many places. So much continues to fall on so few. And the interdependencies has been raised already by Nima and Lynn. So when we consider intra-crisis impacts, the interruption of health services, the diversion of a workforce to a vaccination campaign, the fiscal space for health that Nima talked about, the economic shock means sustaining what was spent on health pre-pandemic over the next few years in these largely public sector funded systems is going to be more challenging without good argument for health. So there's more risks and less resources. So some of these impacts have directly shaped how Australia has worked with our Pacific family in the health response. As an example, our Vaccine Access Initiative has made a commitment to comprehensive coverage of vaccines in the Pacific and Timor. We've pledged 15 million doses to the Pacific and Timor. To date, we've delivered about 2.2 million with end-to-end system supports and technical assistance and funding the regional organisations amidst that. And I'll finish by saying, in a way, we were prepared, I think. Of course, no country was prepared, but we've been part of a gradual progress in strengthening capacities under the IHR in our region for 2 decades. We've called it IHR since 2005. And with Australia's Centre for Health Security Investment, to round back to a point made at the beginning, with the projects that Australia had invested in the region, in the core capacities of surveillance, laboratory testing, etc., they were very quickly and able to pivot to support intra-country COVID responses in the Pacific. I'll stop there.
Thanks, Steph. It's a nice tale to what Nima and Lynn mentioned about when you mentioned engaged leadership and engaged citizens has been part of the answer. I think that's a nice synergy. Sonia, representing the Secretary of the Pacific Communities, what's your perspective?
Thank you, Adam. I think the initial reaction in the Pacific was a bit of a wake-up call, yeah? It's also an opportunity to take stock of where they were. And I think Stefan has referred to, and yourself, Adam, it basically, the pandemic unmasked the fragility of the Pacific health systems. And it just exacerbated because of the geography in my backyard, the staffing numbers in the systems, staffing levels, the resourcing that's been mentioned, and also the dependent on one or two sectors for economic viability. So it was basically a big wake-up call for the Pacific. But conversely, it was also an opportunity, as been alluded to before, an investment and a focus on the health sector. Yeah, so there's been significant support from a host of our friends and families in the development partner space to support the Pacific. And again, from a personal perspective, we, with WHO and all the other key partners, formed or worked under the Joint Incident Management Team that was created. And lo and behold, I didn't realize that there were a lot of organizations and entities that were doing work that added value to what we do in what we call the traditional space, the WHOs of this world, the UNICEFs, the UNFPAs. Yeah, we have Oxfam on this call. They're doing wonderful work in an area that, to me, was a non-traditional partner. So that, to me, has been a significant beneficiary of this pandemic, if you want to call it that, is that I have been exposed to a host of networks that I would not have had the opportunity or the privilege to work with because of this pandemic. So I think through that, and I think Steph alluded to, prior to the COVID, only 5 countries had PCR testing capabilities. Within the space of 18 months, we now have up to 19 or 20 countries with PCR capabilities. And those that haven't are because of economies of scale and volumes. Yeah? So again, this is some of the benefits of what COVID has presented us. And as Steph has said, you have 22 organizations around a table, and you have your different mandates, your different agendas, your different egos, if I may call it, and say that. So we were able to put those aside, recognizing that the big picture here is to respond and react and support fragile health systems. Thank you, Adam.
Thanks, Sonia. That was a nice, passionate account of what's going on. And I think your comment there about, there's motivation and there's opportunities, and these networks that have formed because of the crisis now can be harnessed moving forward. Let's move into our discussion, our moderated discussion now. And please, anyone who's got any questions, please pop them in the chat, and we'll get to those as we move through. But I'd like to start with Sonia. You're someone who's perhaps closest to Pacific Island governments. Could you give us a sense of what it's been like on the ground for the Pacific nations over the last 20 months, and what impacts the health sector's feeling, direct and indirect, as a result of the pandemic?
Thank you, Adam. Again, I'm someone that speaks frankly. I think the initial reaction in the countries was this utmost panic. Where do we start? There's a lot of uncertainty about the etiology of the disease and what the appropriate responses need to be implemented. There was a multitude of global guidance that was developed at the headquarters in Geneva, Washington, that needed to be contextualized to the Pacific. On reflection, there's a bit of information overload, trying to translate that into something that is meaningful to the practitioners on the ground who have multiple hats. So again, those are some of the reflections. From an organizational perspective, there's a bit of where do we start in SPC. So one of the first things we did was because we have a clinical services program, we recognized that in a worst case scenario, the hospital capacities would be stretched in the event that there's an outbreak. So we did a quick ICU assessment to sort of inform us where we are in terms of ICU capacity, staffing, equipment. And the outcome of that assessment provided us some sound information and data to support our strategies and our investment in our support to the countries, and that has unfolded in the investment that we've received from a host of our partners to support the work. Of course, everyone was repurposed. If you were the nurse delivering babies, you were repurposed into a COVID team. So again, an unintended consequences is that the traditional essential health services that any country delivers in what we call peacetime were also affected. Yeah, people were missing their diabetes outpatient clinics. People were missing their child immunizations. Mothers weren't coming in for their antenatal care. So those were the unintended consequences in the system. Again, a lot of the Pacific countries are dependent on overseas medical referrals. Once the countries then either themselves close their borders or those recipient countries close their borders, again, they weren't able to transfer the patients that usually were transferred overseas for tertiary or secondary medical attention. Again, it was mentioned earlier, supply chain issues were a massive challenge. You have effects on medical supplies, you have effect on medications for non-COVID related patients that were out of stock, and even had to go to second and third generation medications in the absence of the first generation ones. Again, vaccination rates showed a decrease because everyone was refocused on the COVID response. Some of the social implications, we've seen an increase in gender-based violence and domestic violence as a result of people being cocooned up at home, no income, lost their jobs. So the next best thing is to get up and get into an argument, and unfortunately, violence occurs. Again, our children, school has been affected. I mean, in Fiji, we haven't even, my children have been homeschooling for the whole year this year. Yeah, and we see how challenging it is for parents, for children, and I have the utmost respect for teachers, including nurses now. That's what COVID has taught me. I think those are my initial reflections of Adam. Thank you.
Yeah, no, that's great, Sonia. I think it's in Australia we obviously had lockdowns and we had supply chain issues and other things too, but to appreciate the challenge that a Pacific Island country, which has been basically locked, or some Pacific Island countries which have been locked off from the rest of the world in response to COVID, have had to face. It's mind-boggling. Lynn, can I ask you what your organisation and what the NGO sector have seen over the last 20 months, specifically looking at the Pacific context?
Thanks, Adam, and thanks, Sonia. I think an observation we have is that there has been, in the spirit of pivoting and trying to respond to the circumstances we find ourselves in, there's been probably a healthy and useful blurring of old boundaries around funding programs and specific purposes. So if you take, for example, sort of development and humanitarian funding streams, practically on the ground, the folks that were available to think about problems and resolve those problems were able to work really very dynamically and closely together, partially because of, by necessity, of course, but also in part because of the second point I will make, which was, if you take an Oxfam position, it's usual that we're able to offer surge support to circumstances that require them. But of course, this pandemic in many cases have required communities, for reasons of geography or decisions that have been taken, to really consider the resources available within the community, and the boundary between those who are affected, for example, our staff, and their communities has really blurred through this process by necessity. And that's a huge challenge, right? Because, many times our workforce are themselves and their families affected. And I know that's not just true of us, it's been true right across the health system. And it's one of those elements of volatility that we need to learn to plan for and with. And I think that's been one of the incredible learnings out of this process, is that we have been able to scale, incredible sort of lo-fi but effective responses that are occurring in one setting, and swiftly, the NGO sector has been very good at this, I think, swiftly bringing it to other sectors and enabling communities to stand up appropriate responses. But we have absolutely been challenged, as I say, by those impacts within communities and families. And, you know, Samir mentioned it, but I would have to say too, we are deeply concerned about the vast range of other impacts occurring in the communities as a consequence. So, you know, Steph's point about intra-crisis is really very much the way we're thinking about this too, which is that the economic impacts, you know, the gender-based violence impacts, the young people that are not adequately engaged in schooling, you know, these things together have the capacity to really profoundly affect our development goals and expectations. So there's some big conversations that need to be had about how we support communities that have stood up responses but now need to be looking to next steps.
Yeah, no, it's your point is well noted, that it's the recovery from this is not going to be a health recovery. It's a recovery across society, and hopefully a new way of doing business, development business, and others. It's a nice segue to the next question, actually. I want to ask you about about global mechanisms. So, you know, the pandemic was not unexpected. You know, there's been years of effort put into pandemic preparedness across the globe, and Steph, you mentioned that earlier. You know, what has COVID taught us about the adequacy of the mechanisms that we had in place? You know, things like the IHR, the International Health Regulation, sorry, for those that aren't familiar with the acronym, or the Global Health Security Alliance. You know, what do we do well under those mechanisms, and where could they be improved? Steph, maybe I could start with you to speak from the Australian government perspective, and then I could flick over to Nima to talk more from a bi-regional or more broader perspective. Steph?
Yeah, thanks. So I think lots of things did work well in and have continued through WHO's operational role, and I'm pleased Sunia mentioned the joint IMT in the Pacific and the true partnership in our region, which was an on-the-ground response. I think, you know, what has come out of the IPPPR review, the independent panel review of pandemic preparedness and response, and several other reports, sort of always hone in on a couple of key findings. The need for a stronger independent authoritative WHO as the global norms agency and overseer of health emergency responses, and a greater accountability on the part of countries in their own progress towards improved health security, and accountability that potentially has not been as realised through the IHR as it could have been. And one, you know, the example that's oft been talked about, I mean, I think it's personally great progress that we had joint external evaluations, national action plans for health security. Every crisis, and unfortunately we are in a crisis cycle in public health for reasons that we wish we could change, does spur some improvements in how the global system organises itself. And the JEEs, the joint external evaluations, were part of that pathway of progress. But when countries went through them and had their list, their national health security action plan, and a list of 14 areas to improve the core capacities, there was never a clear source of smart financing that enabled a development or improvement of those core capacities. And I say smart financing because I think it has to be a combination of domestic resources for health and smarter ways of using overseas development assistance for health to stimulate investments in health security at the country level. So I think what we want to see, and the other major gap that doesn't really come in the IHRs that we need to recognise, was the research development access distribution pathway. Now there's a lot to be impressed with how CEPI, COVAX, the ACT-A institutions, all the WHO partners have come together in that effort. But I think we can recognise that that was a sort of a global gap that is being improved on. But back to the original question, smarter financing for preparedness, political leadership for health security. Lots of reports have pointed to high-level political engagement both during COVID and beyond COVID, and potentially ways in which to think about recognising the interdependencies of health security in country A to country B, and building in a more periodic review of how countries within regions are progressing to improve health security. I'll stop there.
Interesting. I think, it's often said in the Pacific that, one size fits all doesn't work in the Pacific for lots of reasons, and that, purely just the lack of human resources to be able to do all these big programs, which in any other setting you would have, teams upon teams of people working on, multiplied by the topography challenges, et cetera, and I'm sure Sonia will talk about this later on when I get to him. Nima, sorry, I said I'd flick to you next. Be interested in your point, your perspective from the regional perspective, but also your history in working for human resources for health, and how that impacts on capacity to develop systems in small and developing state contexts.
A big challenge. I think Stephanie and I can complement each other, because when she talks about her security issue, I can bring out the linking of security to the rest of the health sector issue, which is there. But let me start with a thought. Imagine if there was no IHR and COVID happened. Imagine if there was no 15 years of building, however imperfectly or perfectly we tried. Imagine if there was no APSED 1, 2, or 3, and this thing happened. So let's pay due acknowledgement to the work that IHR as a mechanism did in building capacity in a lot of the countries. And it always had its drawbacks. JE came around because of the Ebola response in West Africa, and it showed that self-reporting on how well countries do on IHR doesn't pay. I used to work on IHR in Cambodia for a long time, and in China. So I was, part of the people who was working with the ministry doing the IHR reporting. And I remember how things got fluffed when it came to the report. So there was a reason for JE came into place. Now, when we look at building on the independent panel, working with other academics in the region and globally, Asia Pacific originally did quite well when it came to COVID. Now that could be because of the early onset lockdowns and border closures. I think, and I think our experience has shown, is that because of exposure to SARS, because of exposure to MERS, they had the capacity, historical, institutional memory, and governmental memory to respond fast, whereas Europe just didn't have that. And they responded fast to a number of different areas. One of the main areas, if you look at it, was the development of an independent expert panels, which were providing advice at a very high level to the government. So there was introduction of evidence on that, and a responsive government, a responsive political entity, because that experience of SARS, that experience of MERS in South Korea, and that actually made a big difference in the speed of responsiveness. The virus as it is finds any crinks in the defense system. So in Singapore, what we saw was that it was the migrant, the migrant workers, because they were cohabiting in very concentrated areas, became suddenly a flashpoint for an outbreaks in early or mid 2020s. I think what then happened is, because of the success in the public health measures, there wasn't as much focus paid by the public or the governments on the vaccine issues. And where we saw was that early commitments, early contracting for vaccine came from Europe and USA, and suddenly they took over and it came to being able to control the disease much better than Asia. And we see that only now Asia is beginning to come on par when it comes to immunization, generally speaking. So I think that was one of the issues that we saw. Global Health Security Index, what pandemic showed was that what COVID showed, but the GHSI just did not represent the reality. And I think some of that is because we were looking at emergency response at IHR strengthening at 13 or 14 areas, very, very independent of the rest of the health sector, never mind the rest of the community and the government sector. And I remember that, we will go in there and we'll discuss, okay, we're going to do this training, we're going to do that training, but it wasn't linked to the overall architecture, health architecture in the country. Same with lab capacity. I remember, for example, that there was a drive under IHR to build in virology diagnostic labs in the absence of any bacteriology, and there was a conversation going on saying that, well, we need to get the basics in place first before we start looking at virology. If you don't do bacteriology, you can't. There's no point. You will drown the system. So it's about understanding and putting us in the whole IHR-related strengthening areas within the wider health system, and that comes in the linkage to HRH and the importance of building a responsive human resource for health. There is currently, and probably we'll come back to this, if you look at the UHC, if you look at the SDGs, if you look at how we're going to build back better, for want of a better word, we are looking at primary healthcare as the engine to do that. And that fits in across all of this. That fits in also from the view of the community engagement. That fits in from the view of having local people who can manage or who can be involved in outbreak investigation, as opposed to sending teams, and also improving diagnostics, improving NCDs, etc., etc. So there is a potential. The challenge, of course, is in geographically isolated countries. That's how do we actually do this, and where does the roles of, for want of a better word, digitalization of the health sector come in to support some of these issues, which I'm sure we're going to bring that up. I'm going to stop for now, and I'll wait for the next question.
Well, I think it's a nice segue, and I'd like to ask Sonia actually. Nima, you mentioned the success or the, what would the world be like without the IHR or without ABSED? Sorry, for those that don't know, the Asia Pacific Strategy for Emerging Diseases, the kind of the regional strategy for responding to pandemics, and the need to build foundations as part of system strengthening. Sonia, how can the global mechanism support the Pacific Islands better? Like, what would you like to see from an organisational perspective, or what do you think ministries of health would benefit from these global pieces of, governance architecture, if you like?
Thank you, Adam. I don't want to repeat what Nima and Stephanie referred to, but I just want to echo their comments. I think with hindsight, the instruments, despite its flaws, I think it has a place as a one-stop shop, so to speak, where we can garner collective and collegial basis to combat the common health threat. I just want to speak to the Pacific here. In some of the annual core capacity assessment that's been undertaken, it's become apparent that there obviously hasn't been enough resources to invest in across the 14 domains, so to speak. Yeah. So what has happened in the Pacific? There's only been investments in preparedness, surveillance, and laboratory capacity to some extent, at the expense of point of entry, quarantine, isolation, and contact tracing, as COVID has shown. Yeah? So again, and that has been compounded by a lack of standing operating procedures and capacity building programs to support that undertaking. So again, those are some of the lessons learned from the Pacifics. And going forward, and without stating the obvious, there needs to be continued support. And I think Steph referred to the element of independence is critical. I think Nima also referred to that. Yeah, the self-assessment, I think, has proved well-intentioned, but is not appropriate. There also needs to be better coordination at the national level. Some jurisdictions do it well in the Pacific, some don't. I referred to capacity building earlier on. I can never pronounce it, Sunism, and development of One Health programs. Again, COVID has exposed that, yeah? That linkage between human health, animal health is important. Something that's always been a challenge, and we've seen that with COVID, is data sharing. Yeah. Again, there's no regional data sharing in the Pacific. We have the PPHSN, but again, it's self-reporting driven. Yeah. So there needs to be some sort of arrangement where we are able to freely share information. And again, point of entry and border control. But again, I want to go back to what Steph referred to, the smart financing. Despite how realistic we are, I see it very difficult that domestic financing will be available to support countries in this space, like a lot of other things as we've experienced. And that's the honest truth here. So again, I think it's we need to be able, the countries need to be able to demonstrate to partners that their investments are going to be put for the purpose that it's being provided. I'm not saying that it hasn't been done, but again, I find it very unlikely that there'll be domestic resources forthcoming to support this, despite what COVID has identified. And then again, I guess the challenge is for the countries to be able to be in a position to comfortably justify and satisfy the partners' requirements, if you want to call it, for receiving funding to support this. Otherwise, the next outbreak is around the corner. We will still be having the same conversation. So those are my reflection. Financing is required, independence, and there needs to be an instrument, but it needs to be fit for purpose. Thank you.
Some great points there, Nima. I'd like to discuss more about regional approaches versus country approaches and how the two work together to actually achieve true system strengthening. But I'm going to go to some of the questions that are coming from those listening or in the audience. There's quite a few questions about the impact on NCDs and other health service delivery as a result of resources being diverted to COVID. And a question here is how much resources should be added to the anticipated burden of future surges of NCDs in the Pacific. Maybe that could be rephrased as, what focus should be put on such programs, and then specifically around cancer care and cancer screening is a question. Maybe start with Lynn. Is that okay, Lynn? I don't know if you feel comfortable answering that, but about how we should be balancing the response to cover all the burdens of disease, understanding that the Pacific Islands are facing an NCD crisis as well as, still managing communicable disease risks.
Well understood, and a very important question. I think, we're all troubled by the dislocation effect in health systems, in all systems, as to what folks are missing out. I guess my response would be, as it is with a lot of these questions, back to the point Nima raised around, engaged citizenship and leadership. So we would be saying that, investing in, yes, capacity building, development of civil society, local organisations, Oxfam has long advocated for, and it does a lot of work in terms of women's participation in leadership across the Pacific, because we see this as a critical driver for a great many of these changes that we want at a local level in terms of communities' ability to reckon with. And this goes to the NCD issue. Ultimately, the closer we can get that kind of decision making about what is going to make a difference in a community, what the key priorities are, and how we might change patterns that we know are driving NCDs, is through community engagement and ownership. We know that. So we have to be as invested in that, top of the cliff community ownership, awareness, knowledge, priority setting, and we know the world over that there's appetite for that. That if we put in place the right supports, communities do through organising and community networks, they do want to and are willing to set and agree priorities and thus make the sort of necessary changes. The other thing I will, of course, say is, we must all recognise that one of the big drivers, of course, of the NCD piece is the commercial determinants of health piece. And again, that takes us back to communities being sufficiently organised to be able to defend and protect their rights and thus their longer term health outcomes. Yeah.
That's a wonderful segue into, back to Sonia. I know trade and NCD risk is an area that your unit focuses on. Do you have any comments to add about those risk factors and how we can come out of this stronger, so we're protecting both communicable disease risk but also NCD burden risk?
Thank you, Adam. I mean, our team is very concerned about what some of the significant progress that we have we've managed to realize in the NCD space has been halted through the pandemic here. As I referred to earlier, patients are missing out on their outpatient appointments. There's been a lack of medication available to them, and again, these are some of the consequences that has been taken away in just the last 2 years, that has been built over 10 to 15 years investment in supporting the programs. We are taking a step back to see how we can re-engineer the support that we provide to countries, given the setback that we are currently experiencing. The question with regards to cancers, Adam, what was that related to, please?
Good question. So the question around cancer was, let me find that one. Real challenges in maintaining cancer care, especially screening for cancer during the pandemic. We know that the health system will seek patients later and in a more severe stage of cancer. How will the Pacific respond to that challenge?
Yeah, I mean, this is an area that, again, is not as well developed, cancer care in the Pacific. I mean, we don't have the tertiary services available, so it's very, very in its early development across the Pacific. So again, if anything, this is just exacerbated the cancer services in the countries. Sure. We don't have the resources to undertake. If there are resources to undertake screening, we don't have the resources to treat and manage those patients. So again, it's this dilemma that we have. We advocate for screening, but then we don't have the services to cater for them once we identify those patients. So these are some of the challenges that the countries will have to face. I mean, myself, I was a former CEO of a health system. So these are some of the difficult challenges I used to be presented with. Do we invest in a cancer screening program at the expense of the broader public health benefits? And again, COVID has highlighted these. And again, as I said earlier, the SPC team is taking a step back to see how we can recalibrate the work that we do. We thought was the best way of doing it prior to COVID, but COVID has told us otherwise. So I trust I've attempted to answer some of the questions.
No, it's fine. I think it complements or highlights what Nima said before about the need to build foundations for systems before looking at more advanced service delivery. And we know that in some parts of the Pacific, particularly in remote and rural areas, that the basics of universal health coverage, the delivery of primary health care is still weak and still struggling. So lots of challenges. Another question that's come in is around stockpiling and how Australia faced issues with stockpiling during the pandemic. I think the question is asking for some insights on what the effects of lack of supply chain was for some of the Pacific Island countries. Steph, are you across those topics from Australia's perspective? I know that the DFAT did a lot of work in PNG with vaccines and other things. Maybe you could start if you'd be willing.
So through Australia's development assistance response and COVID response in the region, we were very quick to work directly to acquire. At that time, we were buying PPE effectively. Now we're buying more than PPE, but we were buying PPE and preparing outbreak response packages for what was the then guidance of adequate for treatment of 50 patients. So if you had a healthcare workforce, how could you protect them for the first 50? It was a planning frame, but we had a stockpile and we have delivered that PPE, and we also procured on behalf of some Pacific countries in the early phases when the markets were so tight. That was one action, and we contributed to regional procurement and countries buying their own through some of the bigger and more effective ways to procure commodities through the multilateral system. So stockpiling was an issue across the world, but there were ways in which we addressed it in the region through direct and indirect support in order to have that flow. You mentioned vaccines in your segue to me, Adam. I think, we have been sharing vaccines from Australia's production capacity since, I'll probably get the date wrong, it feels like about years ago. It was probably March or April, very early on concurrently with Australia's domestic vaccine rollout. We have continued to deliver against our commitment to supply to the region. So in your question to the Australian government, no, I don't think stockpiling in Australia has affected our ability to support the Pacific with COVID response or vaccines. But I know Sonia will have a comment probably about the humanitarian corridor and other ways to keep channels open over.
Well, before we move to Sonia or to somebody else, I know that the Pacific is really thankful for Australia's support with supply chain during the pandemic, and the vaccine. I was talking to the Undersecretary of Health in Fiji recently, and they were speaking very highly and thankful for Australia's support. So well done. I'll go to Sonia in a second, but Nima, you wanted to make a comment on the NCD issue and the discussion around how we balance this response to pandemic threat with need to supply and support NCD burdens and risk management.
Yeah, thank you for letting me come back in on that one. Here's the when it comes to NCD, we have to understand about a few things. One of them is a timeline issue. If you look at the actual global action plan, the best buys, vast majority of them are about prevention and actions which you're not going to see any change in your current health, morbidity or mortality. Action which have a result 10 years, 15 years, 20 years down the line. It's about cutting down on tobacco, it's about improving exercise, it's about eating better. So we have to acknowledge that some of these actions that we are recommending, the consequence is not going to be seen in one or two political cycles. They're much more long term. The demographical changes in effect. If you want to look at it. There are other things which are much easier, much more faster. And those are the secondary screening. Those are the diabetes and hypertension and pap smear screening and mammography. And again, a lot of those things, as a screening program, they will cost, but they don't necessarily need to involve a expensive individual treatment. Hypertension, diabetes, as a screening program, you're going to decrease potential of getting stroke, cardiovascular disease, more heart attack. So again, it's about understanding the timeline. And the other thing which that I've noticed is that in a lot of countries, the health system hasn't yet fully acknowledged that the disease burden has changed. We're seeing a lot of strength putting on in the maternal child health in the neonatal areas. Historically, that was the case. Well, what we are seeing now is that they're either in the dual burden or they've moved to a proper NCD burden. away from the MCH, away from the communicable diseases. But what we are seeing is that the programs are actually still very strong in those traditional areas, and less so. And it's about acknowledging that as the disease burden is changing, we have to change the way that the health system is functioning as well. And it has to evolve as well as the disease to make sure that it's responsive to the new challenges. And I think that's it. And by nature, it is going to be behind the time. It cannot be ahead of time. But we have to acknowledge that we have to actually actively try and see some of those changes. And there will be institutional challenges to that. And that is just the fact that we just have to accept. So I just wanted to bring some of those issues, and again, very much generously, I'm not talking about specifically about the Pacific, but those are the trends that we are seeing in other parts of the world. So thank you for that.
No, interesting, and it's well noted. I think it segues nicely with Sunya's comment before about, you know, there's multiple parts, isn't there? There's not just the screening, there's not just the treatment, there's not just the referrals or the continuum of care, and all those parts need to be in place to be able to truly address that NCD risk. And that's obviously a challenge in lots of parts of the world, but particularly in some Pacific Island countries. I'm aware that we've got 5 minutes left, so I'm going to ask one more question, and then maybe we can do the wrap up. The pandemic has shown that inequity in society, or in social inequity or economic inequity, you know, is a key factor. Lynn, would you like to touch on that with, you know, reflecting on your work with vaccine rollout?
Sure, and you know, thank everybody for a great conversation. Well, that's right. I mean, Oxfam would say that the pandemic has laid bare the structural inequalities that were problematic before, that were making our development goals resistant, and that what the pandemic has really done is expose them in an extremely stark way. And I think, you know, the comment I most often make is I think Australians will be troubled and surprised to find how the world has changed beyond our shores when things allow us to be more focused beyond our shores. I think we're all in for a bit of a shock that actually much has changed, and so we need to redouble our efforts from my perspective, because you know, we've got some big challenges ahead. Yeah.
Good point. I'd like to explore that further, but we're running out of time. To wrap up the panel discussion, I'd like to invite each of you to reflect on, you know, what your key lesson has been from the last 20 months, and then how that lesson may be practically implemented to make the Pacific health systems, or to support Pacific health system strengthening, so that countries are more resilient to future events such as pandemics and other global public health emergencies. Think for a moment. I'll start with, who shall I start with? Let's start with Steph. Is that okay?
Sure. So I think the lesson is that we just have to keep learning. I mean, adapting and moving to this crisis amidst all the other health challenges, and to keep learning, we have to be connected, talking, communicating, and continuing to ask questions, never taking anything for granted. That would be my reflection. And the other point, to bring it back to the Pacific, is that the solutions are already in the Pacific. It's the enabling environment that we need to create after.
Well put. Lynn?
Yes, Steph sort of nailed it, really. I think my lesson would be that we can make very significant investments. In fact, you know, like what we've seen happen over the last couple of years, not just in, you know, this area, but in Australian domestic policy, is that we've seen very significant shifts in attitudes to public support for social and economic goods. And we need to ride with that positive experience that we have had of those kinds of large-scale public investments in the interests of, social and economic context. So I think that's a lesson worth taking stock of, and I think it's one that certainly from a public policy perspective we can and should build on. And if I can be cheeky and have one more like Steph, we saw incredible capability, adaptation, response capability. That there is rich and fertile ground for us to work on moving forward, no question.
I think building on Australia's, pivot is probably the wrong word, but refocus on the Pacific and refocus on health in the Pacific before the pandemic. It's lots of opportunities there. Very quickly, we've got 1.5 minutes left. Nima, I'll reflect on you, and then I'll finish up with Sonia to have the last word.
Let me then give a one-liner. I think we should use COVID as an opportunity to bring out health into the focus when it comes to cross-governmental discussions, and use that as a means of increasing the voice of the health sector. Not just about financing, actually the voice of the health sector, shifting the idea that we are a sunk cost in the government economy into a much wider dynamic conversation.
Well said. And last word, Sonia.
Thank you, Adam and the panel. I think just building on Steph's comment, enabling environment, I think, and I say this with utmost humility, that needs to be matched with Pacific leadership in the national governments to be able to realize some of the significant investment and unselfish support that our partners like Australia and the other multilaterals that are providing. They need to come to the party as well. And I say this as a Pacific Islander. Sometimes I pull my hair out. We have all this wonderful support, but the response is not as forthcoming as we would like it. So I think that's a take-home message for me. Also, the joint IMT, despite its flaws, it is a model that can be applied in future responses that we will no doubt have to deal with. A minor tweak, but it's demonstrated that it's a mechanism that can be used. Thank you.
Thank you all, and thank you for staying to time. I think we're right on. Final words. The 3 take-home points that I've written down from the session was that the enabling environments is important. Programs only work if they have an enabling environment, and the development in the future needs to strengthen that. That the pandemic and the recovery from the pandemic is an opportunity to reframe what health means to society, and that we need to look to the Pacific for answers to the challenges, not come from the outside. Thank you, Nima, Sonia, Lynn, and Stephanie. Appreciate your time.